Good afternoon, everybody, and welcome to NHS Leeds CCG Annual General Meeting. The meeting today is to cover the year 19 to 20, but of course so many things have happened in the early part of this year that we're going to be covering some of those things too. So to introduce myself, I'm Jason Broch, I'm a GP and I'm the clinical chair of the CCG. So in today's meeting, we're going to broadly do a few things. We're going to celebrate our achievements and our people over the last year. We're going to talk a little bit about the lessons that we've learned, especially in recent times, and then we're going to try and describe some of our future as well. The agenda is relatively straightforward, and we will move through that. And we have in the facility online the opportunity for you to submit questions in the Q&A function. Now, we've already had quite a number of questions submitted, and we will try and answer as many of those as possible. But if there is time at the end of the meeting, we'll also try and address any further questions that you put in that Q&A function. If we don't get time to answer any of the questions, what we have undertaken to do is make sure that we publish on our website all questions and answers so they can be accessed afterwards. Okay, so I took over as chair in July this year, and so it would be remiss of me not to start the meeting by thanking my predecessor, Dr. Gordon Sinclair, for his time over the last few years and his commitment in building the CCG into what it is today. So just on behalf of the governing body and behalf of the CCG, I'm sure everybody will join me in sending that thank you to him and wishing him well for his retirement. We've also had some other people that have been part of our governing body and organisation that have left in the last year. And I'd like to thank Catherine Sheeran, who was our Director of System Integration, who moved to a new role recently. I'd like to thank her for her input, especially into some of the key strategy development that we had over that year. And of course, I'd like to thank Sue Robbins, who was our Director of Commissioning, who retired after a very full career earlier in the year too. There are two other people that I think it's really important to mention as well. So the first one is Sue Breer, who was our Chair of Audit and lay member. She left the organisation a few months ago, and we want to thank her for her time and commitment to the organisation. And then someone who has worked with the NHS in Leeds for a long period of time in the PCT, and also more lately from within the local authority, Ian Cameron, the previous Director of Public Health. We'd like to express our thanks to him and we wish him well for retirement as well. But with people leaving, we have people joining us too, and I would like to welcome today Victoria Eaton, who is the new Director of Public Health. I'd like to welcome Helen Lewis, who is our Interim Director of Acute Commissioning and Mental Health and Learning Disability Commissioning. And one thing we should also acknowledge is Tim, who has been with the organisation before, has now become formally our CEO in the years 1920. Okay, without further ado then, can we move on to the main agenda, and I will hand over to Tim.
Thank you, Jason. Good afternoon, and again, just to echo Jason's thanks and welcome to everybody for attending this today. So what I wanted to do, and I do hope all of you that have wanted to have managed to get a copy of our annual report that sets out in significant detail our achievements, a review of the year, and those areas where it's been a real challenge as well, because we don't want to just rest on our laurels, as it were. We do want to continually move forward, and there's always challenges as well as things to celebrate and recognise and good achievements. So what I wanted to do now is not go through in huge detail every single achievement of the year and every single challenge, but perhaps just to pick out a few highlights. So if we could move on to the next slide, I just wanted to cover in particular three highlights of the year. The first one probably relates back to a challenge that we were facing in previous years, and it's an area we knew we needed to improve on. Our access to psychological therapies was not as good as it needed to be, and we'd recognised that. However, what we wanted to do was go beyond perhaps some of the traditional approaches, seeing it as a very separate service, and to look in a broader way at how we went about addressing some of the challenges that individuals in our communities faced in terms of access to psychological support. So we work very closely with our own GPs and also with other providers in the city, both statutory sector providers and also third sector, to develop a Leeds mental wellbeing service. And this was launched in November in 2019 and is a really groundbreaking piece of work that goes well beyond the pure access to psychological therapies and builds in a range of other things: primary care mental health liaison, and perinatal mental health support as well, as a more broad offer really across the whole range of community-based mental health. So it's a 5-year contract. It's worth across those 5 years up to £76 million and includes new investment again across the 5 years of up to £20 million, and is built around a alliance of providers. So in that sense, it also reflected our commitment to develop and focus on outcomes rather than inputs, to ensure that we are building a genuinely integrated system with partners working together rather than in competition with each other, while still, of course, having to abide by some of the national rules around both IAPT, but also in terms of procurement. So that was one of our really big successes. Just as COVID hit, we were beginning to see the real fruits of that. Obviously, it only started in November. But what the other thing it does mean is that we would expect during this current year that we're investing well ahead of the mental health investment standard. So probably somewhere in the region of about 4 million more than we had originally planned, we would have expected to. So it's a real commitment to the mental health and the mental well-being of the people of Leeds. So that was a great piece of work, not just by us, but by our partners in the city, a whole range of them. Leeds Community Health Trust is the lead provider, but with a whole range of other providers in support from the third sector and the statutory sector, and including our GPs. Another area where I guess we wanted to be at the forefront, we'd already done quite a lot of work around sort of social prescribing and understanding that when people are presenting with problems, particularly in primary care, whilst often they have a medical component, that medical component isn't divorced from their wider social situation and their mental well-being as well, and that social prescribing has been shown to have a really big impact. So we've already committed quite a lot of investment to that, and then more recently there's been a national push as well. So during 2019-20 we invested over £4.5 billion to support GP practices with links, really to make it a significant difference in terms of those. Single citywide service run by community and voluntary organisations, led by Community Links and facilitated. Again, that concept of working in an integrated rather than a competitive way, which is really important to the approach we're trying to take now as a CCG. We put up there one example, there are dozens of these, but the Foundry Lane Surgery in Seacroft, it refers patients to 8-week art therapy courses to help those who are experiencing a range of emotions, including anger, low mood, depression or anxiety. Those things that perhaps wouldn't show up further on into the sort of in-depth mental health services, but are really important and really affect people's lives and their ability to function. And that's the kind of thing that we can address through these link workers and the social prescribing schemes that we've done. And it was really exciting to present some of that to one of our local MPs, again, just before COVID started, and to see the work that was being done at other practices across Leeds. Another area where we again wanted to be going beyond where perhaps we'd been, we were already good, but we wanted to be better, was the Leeds Cancer Programme. So a citywide partnership again, that emphasis on collaboration and integration a core team embedded in the CCG, some of it funded through Macmillan, some of it funded by the CCG directly. And through that, we've been really able to take forward a number of major schemes to improve people's lives. One of them in particular is the Leeds Teledermatology Service for suspected skin cancer. Effectively, this allows us to assess a large number of, allows GPs to assess with patients a large number of potential cancers with consultant colleagues without people having to either wait a long time or visit outpatient clinics. So last year, 8,927 two-week wait skin referrals was received by Leeds Teaching Hospital. Of those, 65% were appointed to a teledermatology triage clinic, and all those patients appointed to the triage were assessed within 48 hours, which is a huge improvement on the long waits that we might have seen a few years ago, and obviously clearly even better than the 2-week wait. So that's better for patients, it's better for clinicians, it's more efficient use, and a really good example of what we've been able to do with technology. So those are some of the sort of really big successes that we had, I think, during last year working with colleagues across the city. However, should we move on to some of the challenges? Thanks, Sam. Clearly, towards the end, February, March last year, coronavirus struck in the last quarter. That has had a significant impact on what we've been able to do. We had to rapidly develop new ways of working safely right across the system, strong again on partnership, and I think we've done really well because we were able to build on the long established partnerships that we already had in place. But it changes how the CCG worked. Most of our staff have and are still working from home, but it also changed the way we worked with our partners, really engaging with them in a new and deeper way, and the strong relationships that have come out of that. Some of the really good examples of the way we've been able to work is our colleagues in primary care have been able to continue to be open, but open in a very different way, and adapted to technology and using virtual consultation as a large part of the response. But also we've seen that sort of change in outpatients and also mental health services. So we're able to keep services open, but do it in a very different way. But it has been a real challenge to the system. The good news is, for example, around cancer, we're more or less caught up. We're back to where the levels that we were this time a year ago, and that's a really positive demonstration of the ability to work together as a city. We also had a really difficult and challenging winter. The whole of the NHS did last year. Particularly, we were hit by some really challenging paediatric respiratory issues quite early on in November that then spread more widely. And the whole city was challenged, working together to deliver. I think where we're really pleased as Leeds, whilst we didn't hit the sort of targets that we were meant to, we did actually see a slight improvement despite those pressures, and against a context with nationally the sort of direction of travel was in the wrong direction. We inched forward and did improve, and that I think again was a testament to the ability of our staff and to the ability of the system to work collectively. So we had a whole range of system-wide initiatives to reduce delayed transfers of care that really took good effect, but we know there's more work to be done around patient experience and some of the outcomes. We've made good progress on system flow, we've made good progress on how we use our ED departments and how we use our wide urgent care response, but we're not complacent, and as we enter this winter with the additional pressures around coronavirus, we know that there is a lot more to be done. The final challenge, I guess, is around system integration. This is both in some ways a challenge and a success. We're having to switch, and I think quite rightly, to switch from being a market-driven system where there were people setting contracts and other providers competing, to a much more integrated and collaborative way of working. Leeds has taken on that challenge, both us as a CCG, but with our partners across Leeds. And we've seen some good work together. So Leeds as a place is very committed to working in an integrated way. We've seen it through our response to COVID, we've seen it through the coming together of the alliance that provided that mental health and wellbeing project or programme of work. We've seen it in another number of other areas as well. So it's not though that Leeds is starting from a weak position. We're starting from a very strong position. Nevertheless, it is a challenge. We're having to work with very different models historically brought in around procurement, for example. So this isn't something that we're doing easily, but nevertheless, we've risen to that challenge and we're seeing good progress. We've also worked really closely together at a West Yorkshire and Harrogate system to develop a new model of working as a partnership, both across the whole sector, local authorities, NHS, providers and commissioners, and also in developing a really robust joint commissioning programme, joint commissioning board, and an approach called Commissioning Futures to develop our commissioning capacity together as a West Yorkshire system, as well as at a Leeds place. And finally, in Leeds, the CCG has committed to really changing who we are and our role within the city, and seeing it much more one as a sort of lead partner in pulling and integrating the city, both by the way we commission and also the relationships that we hold across the range of providers. So those are some of the challenges and successes of this year. I'm going to hand over to Visa now, who's going to talk a little bit about the finances. Visa, our Chief Finance Officer. To hand over to you, Visa.
Thank you, Tim. As Tim has introduced me, I'm the Chief Finance Officer for the CCG. I think I've got an echo. Is somebody on? Thank you. And one of my statutory duties is to tell you how we've spent our money on your healthcare as a city. But I thought before I do that, I give you a bit of context around what Leeds is as a city and where our economics sits. Ideally, well, probably before COVID, and ideally should still be in this position once we get out of COVID. But it gives you a bit of context around how much we spend on our healthcare if you understand the context of Leeds a bit better. Leeds City region has access to a workforce of 3 million, and on top of that, 7 million of the workforce is within an hour's drive away. So within an hour's drive, we actually have access to 7 million people who can work in our city, which is quite a massive resource to have access to. We're a hub for a lot of professional services outside of London, and also a global leader in terms of technology, healthcare and manufacturing. Outside of London, we have the largest university hubs. We have 9 universities doing some world-leading research, but also producing 39,000 graduates, of which 15,000 of them are science, technology and engineering and maths graduates. And we've got one of the fastest growing young population outside the southeast. That's people under the age of 24. So you get a sense of the sort of buoyancy of our economy as the city of Leeds. We also have 126,000 businesses, of which, if you think about COVID bringing the role of manufacturing much more into the spotlight with masks and visors and all sorts of stuff that we're having to think about developing and building ourselves internally, and also we were looking at respiratory aids in ICU. We have 7,300 manufacturing and engineering businesses as well, and we generate 7 billion a year in the manufacturing business. But overall, our economy is worth £69 billion, which, if you think about it in terms of GDP of some European countries, we're actually bigger than places like Lithuania, Latvia, Estonia, Croatia, and similar to the economies of Luxembourg and Bulgaria. So that gives you a sense of how big we are as a city. Next slide, please. Thank you. We've also got a thriving banking and digital sector. We have the second largest centre outside in the UK outside of London, and we employ 28,500 people in the banking and building society area. I was just going to say to you, 3 of the 5 UK's top building societies have their headquarters here: Yorkshire Bank, Leeds and Skipton building societies. We have presence from the 4 big accountancy firms that have major offices in Leeds offering accountancy and consultancy services, and we have one of the fastest growing legal sectors as well in the country. 4 out of 5 of the national offices for NHS England, including NHS England, are in Leeds. That includes NHS Digital as well as NHS Improvement and Health Education England. And we have some of the biggest healthcare data platforms in Leeds as well. The NHS Spine is one that people may have heard of. as well as the Health and Social Care Information Centre. We have 196,000 people who are employed in health and science jobs, and 6 of the world leading life sciences clusters in terms of academic excellence and commercial innovation. And the last thing I wanted to say also, we've got some of the largest concentration of medical devices companies in the UK as well. Very proud to live in Leeds, or work in Leeds at least. So this is how we spend the money that we're allocated normally, and this was what we were allocated last year. The financial rules have changed a lot post-COVID, but this is 1920s position. We received £1.316 billion to basically care for the people of Leeds. Half of that is spent on hospital care in the acute sector. And then just under a quarter is spent in primary care, and that includes prescribing of medicines for people out of the GP practices. The next area of spend is 15% in community care, including care homes. And at the moment, we're spending only 12%, I would say, on mental health services, but that's the area of spend that Tim has alluded to, where we are actually accelerating the level of spend in mental health services, recognising that it deserves greater parity with physical health. And then there's 2% in other areas. A lot of people ask us, how much do you spend on administrating or running the CCG? We have an allocation, or we had an allocation last year of £17 million, of which we spent £13 million on running the organisation, and the balance we transferred to patient care. From 2021, CCG running cost allocations across the whole country have been reduced, so our envelope will be £15 million in future. But again, we're still spending around 12 to 13 million pounds on average on running the organisation. And what we don't spend, we transfer to healthcare services. So that's a question people are interested in. Next slide, please. Just to give you a quick visual of where the activity is being sort of delivered in what way. Just over 65,500 emergency inpatients, 76,000 planned care, planned inpatient activity, 821,777 outpatients and follow-up procedures. Many of these we are planning to change permanently to digital or virtual arrangements post-COVID. Obviously, still bearing in mind that we don't want to digitally exclude any tranches of our population. 261,000 accident and emergency attendances and over 4.8 million outpatient appointments offered, which again we have made sure hasn't dipped significantly post-COVID by changing those to virtual appointments wherever possible. Next slide. And then in terms of some of our key financial achievements, we did achieve financial balance, and that is despite the pressures that arose in COVID late in the year. We also have other statutory duties in terms of making sure that we pay all of our suppliers within 30 days. And the running costs that I alluded to, that we don't breach the 17 million, which we were nowhere near reaching last year, and don't plan to be over that in future either. We also received high audit assurance on financial systems, which means that our auditors are satisfied that we have strong financial stewardship of the taxpayers' resources that are handed to us to provide care with. And Tim has already mentioned the Leeds Mental Health and Wellbeing service that we went out and procured. That particular service, we're very proud of how we went about procuring it, because it was the first time that we tried out a much more co-produced way of writing the specification for the service by involving all of our service providers in a very fragmented market. And we were very pleased to see a coalition of all of our providers, all of whom provided very, very valuable services, but only in pockets, to work together to provide a holistic end-to-end pathway, sort of cohesive service. And that is the area that we'll be investing in over this year, next year, and the year after. I'm very proud that my teams and all of our teams, including primary care support teams, have been able to keep the wheels on during COVID very quickly. Our finance team were able to still do a decent set of accounts, which got a very, very high quality assurance rating from our auditors on time for 1920, despite spending most of their time trying to sort out how we distribute resources to our providers and to the system post-COVID and during the COVID crisis. And the IT team did a fantastic job making sure that all of our GPs were up and running with laptops, working remotely, and to make sure that we had high-speed internet connections in all practices by June. So, you know, some really heroic efforts on the part of our teams, and also our primary care teams, who made sure that personal protective equipment were delivered wherever was needed across primary care as well. So that's all from me. Thank you.
Thank you, Visa. At this point in the AGM, the governing body has met, and on behalf of the governing body, we'd like to formally adopt the annual report and the accounts for 1920. They have been through the governing body with robust discussion, and we are happy with that adoption. Okay, can I hand over now to Victoria Eaton as we go through the next agenda items around COVID-19 and the impacts it's had.
Thank you, Jason. I've just got a few slides to talk briefly about the impact of COVID-19 on the city. Before I do, can I say thank you to Jason for your welcome today, and also thank you to all CCG colleagues for all of the welcome since I started in post on the 1st of March, and all of the work we've done together since then. That working closely with the CCG continues to be a core part of the Director of Public Health role, and never has it felt so important. So thank you for that. I'll just spend a few minutes. I've just got a very small number of slides. If we can move on to the next one, please. In terms of talking about impact of coronavirus on the city, I just wanted to share this current slide of where we are in terms of our current cases. And the caveat to this slide is we just need to be careful, because this is positive cases of people who've been tested. On the first wave in the spring, we didn't have community testing, so obviously the cases were much higher than that. Testing was mainly in hospitals and care homes. So really what this shows is we've had the first wave, and then the very low rates during the summer in the city. Mass testing came in around the end of May, so we can really take the timeline from the end of May to see how we've moved since then. And clearly the stark picture for us, as it is for lots of other places in the country, and particularly the major urban centres, is the very steep rises during late summer and in September. We always expected rises during the autumn and into the winter, but clearly these were steeper and earlier than we anticipated, along with that kind of national picture. So the graph shows where we are now. It does reflect the national challenge. A lot of the challenge reflects what Visa was describing earlier in terms of Leeds as a major urban centre with a large young adult population, and pretty dynamic in terms of its student population and professional groups. So the rates are very concerning and high at the moment, and this is the current challenge we're facing around managing that impact. Next slide, please. I just wanted to put this up because we've had some really useful data on age breakdown of the cases. So this is pretty much the same timeline, but it shows us the age profile of the positive cases. And again, just being careful that community testing only came in at the end of May. What we can see on the right hand side from where we are now is the different age groups in the city that are positive cases at the moment, and the fact that even though the highest age group is the younger adults age group, this is the 18 to 34 year olds on this cut, we are seeing rises in the city across all age groups, generally moving to lower rises the further we go up the age groups. So the over 65s being at the bottom and the younger adults being at the top. It's interesting, it's a different pattern than many other parts of the country. The northeast region is seeing incredibly high rates of young adult population and not much movement in the other age groups. But one of our challenges in Leeds at the moment is that we do have that increase across all ages. And as we watch that week by week, we can see that increase in the older ages increasing and just moving upwards in terms of age groups. So clearly that's the thing we're concerned about in terms of the impact, the greater impact of the virus on those older age groups. So as well as our care home cases and the hospital cases, we're clearly watching the age breakdown really carefully. Next slide, please. So I wanted to put this up because we've just talked about what's happening now with the cases and the shape of that trend at the moment. This feels a really important slide. We could spend more on it if we had more time, but it feels a really important slide to talk about impact now and impact over the medium to long term for the city. And what this slide does is it describes the direct impact of people in what we see as the first wave on the slide in terms of the immediate deaths and morbidity of people affected by the virus. So that's the first slide. You'll see that it's a very simplistic wave in that it goes neatly up and then neatly down again. And obviously from the first two slides, we know that we've not got that neat up and down profile, but clearly we're seeing rises again. So even with the first wave of impact, we are getting that kind of further uptick, and how high that second wave will be will depend on our actions now. The rest of the diagram describes a lot of what colleagues in the CCG are working incredibly hard on and other partners across the city in terms of those second, third and fourth waves of the impact of COVID, both in terms of the impact on non-COVID conditions and the people who have sadly died or have had their health impacted because of the initial focus on COVID in the beginning of the year. So that's the green wave, and clearly that's still a major challenge. And obviously there's a longer third wave of people with chronic conditions who will be impacted by the ongoing challenges of the virus, whether that's about healthcare access or whether that's about the wider impact of restrictions, for example, on people's lives. And then importantly, what we've got on this model is this concept of this fourth waves, which starts pretty early on, but will potentially last for years and decades in terms of the mental health impact, the economic impact of the virus on the economy and people's lives and jobs that will be affected by that. So we know that as well as dealing with the immediate response to the virus, we have all of these waves of impact across the city, and we need to deal with all of them over the medium and longer term. And critically, the action we take now will have an impact, particularly on that fourth wave, around how the city can respond and recover to the virus. So that's a useful way that we've framed much of our work around the impact of COVID. Thanks. Next slide, please. So just to finish off and to link in with what Brian's going to come up with next, just to get back in terms of where we are around our mortality in the city. This is there's so much data around mortality, and this just looks at direct mortality from COVID. We clearly keep an eye on all of our excess mortality more generally to look at the real impact. But this shows the cumulative death rate from the beginning of the virus to now. So although Leeds is very challenged now in terms of its high infection rates, our cumulative deaths per rate per 100,000 people is still very much kind of on the mid-range nationally. We're in the yellow zone on the map. And I won't go through all the numbers on the table, but you can see that in terms of the count of deaths so far from people in Leeds, either people who've sadly died in Leeds hospitals, or the residents of Leeds who've died, whether in hospital at home or in another setting, such as a care home. There's a slightly different way of counting that in the registrar data to the ONS data, but we've put all of those in. But you know, we know we've had around 700 people so far die directly from the virus, many more indirectly from other conditions. So clearly that's something we're going to keep a very close watch on going forwards. And then just the last slide, please. So just bringing that back to the current picture in Leeds, this is the timeline that shows our Leeds hospital deaths, and clearly, thankfully, at the moment it shows a very different picture than the first slide that I put up, which obviously shows that sharp uptick at the end of the timeline to reflect where we are now. Obviously, deaths are still, thankfully, very low. We've had just one very recently, but when we look at the national average 7-day death rate, last night it was on average 23 per day nationally, which is clearly an uptick from where we were. So this is clearly something we're working really hard with partners and being very vigilant and keeping a very close watch around. So that was a very quick whistle-stop tour. I shall hand on to Brian now, and hopefully that ties in with where Brian will pick up. Thank you.
Thank you very much, Victoria. Yes, so the piece of work that was recognised early during the first phase of COVID that needed to be addressed was identifying, understanding and prompting action on the needs of the patients whose healthcare needs had been impacted by the arrangements to meet COVID. So those are patients with non-COVID conditions. So that would allude to the footprint model that Victoria showed in wave 2, which was those patients with urgent non-COVID conditions, and wave 3, which was the interruption of chronic care as a result of COVID. So if we can have the next slide, please. So the piece of work that I led on focused on having patients at the forefront and listening to patients. So we had a lot of information from Health Watch reports, Forum Central and the third sector. We took an integrated approach working across our existing partnerships, and we also ensured that we built the identification of health inequalities into the programme from the start. We had a clinically led cross-system group which challenged and accepted the recommendations. So if I can have the next slide, please. And we found some areas to address, but there was also a lot of good practice that it shows here on the slides. I'll not talk through it, but what I'd like to point out is that patients, public health and social care staff and providers rapidly adapted to different ways of accessing healthcare and supporting patients. Also, the providers, they adapted new ways of working through the use of technology, remote consulting, video, and that worked really, really quickly and really well, and was positively accepted by the majority of patients. We identified also rapidly the need to communicate with patients and to be able to reassure them around the safety of accessing healthcare services, and also that the NHS was open for business. And we quite quickly were able to adapt the estates issues that we had, so that we were able to provide anticoagulation clinics at different places in the community. So if we just move on to the next slide, please. By having a focus on this piece of work through identifying inequalities through populations, we were able to identify specific areas that needed addressing. So as we can see, about the COVID was higher in areas of deprivation. So we had a communications campaign for people with low, medium and severe levels of frailty, and a proactive wellbeing reviews for those patients living with frailty, with a focus in the deprived areas. There was also a recognition that the prevalence and the clustering of lifestyle behaviours was higher in deprived areas, where the digital remote offer can be more challenging to access. So we've got a targeted engagement with key groups to increase access and uptake of the NHS health check and healthy living services. So patients with long-term conditions from BAME and their deprived communities, we've ensured that we are developing a long-term condition stratification model, which helps us to identify those populations who are highest risk of harm from COVID, using both the nationally identified age, gender criteria, along with the comorbidities, which will enable us to focus on those conditions going forward, and to be able to target those populations that are at highest risk and support them to manage those conditions and to reduce their risk of harm from COVID. So we also had national feedback that there was 45% of the general health of disabled children was a lot or worse. So families were actively encouraged to speak to schools, early providers and GPs if any emerging concerns. And if I can have the next slide, please. As well as identifying 75 separate hypotheses and recommendations which are being taken forward through existing working groups, we also identified a number of cross-cutting themes which were quite crucial in terms of how we take this work forward. One of them was regarding digital inclusion and the recognition that digital services were not going to be appropriate for everybody, and to ensure that we didn't risk increasing digital exclusions. We have a focused piece of work on that that's been taken forward through the stabilisation and reset group. There was also a strong recognition about the need to have clear, consistent communications that had a targeted approach for specific populations, and we've identified a systems communication plan to take that forward with some underpinning actions which will ensure that we work in a coherent and integrated approach across the city as we help our populations through this COVID era. We also identified that the estates, that was a clear need to ensure that the services that we delivered to the communities recognise the needs of those communities, and also what assets we actually had within those communities to help support delivery of the services in a different way, both now and in the longer term. And this has been taken forward through an estates implementation group. Clearly, as a result of our new remote ways of working, there's an increased emphasis on self-monitoring, self-management and proactive care. And so again, through our long-term conditions board and frailty group, we're increasing both the access to and support for patients regarding self-monitoring, self-management and proactive care, including the provision of equipment in patients' homes so that they can monitor their conditions. And finally on this, it was about managing patients' expectations, and this was really about ensuring that people knew who to contact when they were on waiting lists, and could be supported to manage their condition and to be able to access help in terms of any deterioration in their condition, and a consistent approach to taking this forward, because we recognise that clearly, obviously, there were a lot of patients who were going to need support that might be waiting longer for their intervention and for their treatment. So if we can just have the next slide, please. And as a city, we did learn lessons about what we do in a second peak, as well as effective ways of working together. So the quick wins that we identified and that we took forward rapidly were about the proactive communication campaigns for people living with frailty. We also secured additional funding to support digital inclusion, and we've got pilots to support people in accessing digital appointments, with a focus in Beeston and Middleton, which are deprived areas within the city. We've also, through our quality improvement scheme with primary care, have a significant focus on health checks for patients with learning disabilities and SMI. We've been really successful with this in this last year, and we don't want to lose the progress that we've already made. And as I alluded to previously, we have risk stratification approach for patients with long-term conditions at high risk of harm from COVID, to help support practices to proactively manage those patients and reduce their risk of admission. And what would we do better next time? About implementing a total triage model, and I can confirm that that is already in place in primary care and also across same-day urgent care across all settings in the city, and that will help to support patients to be able to access their healthcare and their healthcare needs addressed in the best way possible, while minimising their risk of exposure to COVID. Proactive communication with all populations, and particularly with vulnerable families if schools close again, and we were very rapidly able to identify in the initial programme those children who are at risk, and to have a proactive approach to communicating with those families and to managing those situations. Also about considering hot hubs rather than individual practice response for the management of patients with suspected COVID, and the risk assessment of health checks. So we will ensure that patients who need to have those health checks done, who are at highest risk, will be identified and offer that first. Ensuring that we've got a third sector involved is communicating widely with the populations has been a core component as well, and continuing to have those regular cross-system calls which we've had in most with most populations. So at this stage, I'd like to complete that and to pass over to Sarah Forbes, who's the Associate Medical Director, who's going to talk in more detail about the stabilisation and reset, about how the urgent non-COVID conditions and the safe restart of services was addressed. Thank you.
Thanks, Brian. Thanks for that. Obviously, you'll know how we love an acronym in the NHS. So the acronym for our group is STAR, which is about stabilisation and reset. So I'm Sarah Forbes. I'm a GP in Leeds. I'm the Associate Medical Director at the CCG and the chair of this stabilisation and reset group. Just to pick up on Tim's point earlier, and I think the real strength in Leeds is about partnership working, and this stabilisation and reset group is all about partnership working. So this is a group of the chief operating officers of the health and care organisations within Leeds. So Leeds Community Healthcare, the hospitals, the Mental Health Trust, adult and children's social care, we've got public health. We've also got third sector and people's voices represented. So I'm really proud to chair the group, and we initially came together in May when we were starting to come out of the other side of that initial peak that Victoria demonstrated to us earlier. Now, during that time, we'd been advised by, national bodies or royal colleges that we had to step down services, and we didn't have much choice at that point, and I don't think we really knew enough about the virus to know what was safe to do and what we needed to stop doing. So we had to follow the national direction. And as we were coming out of that first peak, it was really important that we stood services back up quickly, got things back on track, and got those, the waiting list down and got people seen. But we were also aware that there would be, you know, potential knock-on to other services if we didn't do this in a coordinated manner. So if the social care system didn't understand how the hospital was changing or when services were coming back online, there was an issue, you know, that there may be this knock-on effect. So we were clear at the beginning that this needed to be a coordinated effort. I guess our role was, you know, it was about coordination. It was anticipating the knock-on effects. But as we've kind of come further out of that peak and to where we are now, it's having oversight to what are people's delivery plans going forward as different organisations, and how do we ensure that we're going to deliver that over winter, for example. So things like having oversight of the delivery plan for flu and flu vaccines. So historically, this has been mainly primary care issuing flu vaccines, and we know that this year more than ever, it's really, really important that we get, as you know, anyone who's eligible in the city, that we get them vaccinated. And so the part of stabilisation and reset is ensuring that you know, that is delivered, and we have, as you know, we strive to have as higher rates as we've ever had in Leeds. If you just flick on to the next slide, please. So I think one of the real strengths that I've mentioned previously was about this sort of strong focus on people's voices, and Health Watch been capturing people's voices, and that's been really invaluable to us to get those insights as to exactly how people are feeling across the city and what's happening with services. So great that we've had, as I say, third sector and people's voices coming to the stabilisation and reset group. And also, as Brian mentioned, those issues that are affecting the whole city, like digital inclusion. And we're acutely aware that as we move more to a digital world and doing things differently, that we mustn't exclude people that can't access digital solutions to some of these problems. And I guess the other thing that we've really focused on in stabilisation and reset is this joined up communications. So the communication teams across the city, led by the CCG, have been working really closely together to make sure that the messages that come out to the people of Leeds are joined up and consistent across whichever healthcare setting you might be in. And we recognise that it's really difficult with all the different messages coming out nationally, and that messages are changing all the time. So what we've aimed to do is get that consistent message for people within Leeds. The other thing that we've done, as you would expect, is continued our focus on improving the health of the poorest the fastest, and also not letting that gap widen because of COVID. So across the organisations and across stabilisation and reset, we've had a real focus on health inequalities, which moves us nicely onto Becky Barwick, who's Head of System Integration, who's going to talk to us a bit more about the health inequalities framework. Thank you. Becky, I don't know if you can hear me, but you're just on mute.
What an error. Hi, I'm Becky Barwick, Head of System Integration. I'm at the CCG. I'm here to tell you a little bit about the CCG's health inequalities work. But before I start going through some of that, I think we've got a short video to show you.
Here in Leeds, we have a bold ambition to make it the best city for health and well-being. Our vision is to make Leeds a healthy and caring city for all ages, where people who are the poorest improve their health the fastest. NHS Leeds CCG want to play their part in achieving this. The events of 2020 have made it more difficult than anyone could have expected to make progress on this. But we're still optimistic of achieving our ambition, vision and the 5 intended outcomes of the Leeds Health and Wellbeing Strategy. 1. People will live longer and have healthier lives. 2. People will live full, active and independent lives. 3. People's quality of life will be improved by access to quality services. 4. People will be actively involved in their health and their care. 5. People will live in healthy, safe and sustainable communities. NHS Leeds CCG spends an annual budget of £1.3 billion across a range of services, from hospital care, ambulance services, mental health, community care, prescribing and general practice. We plan and buy these services for a population of 870,000 people. 224,000 of those are in the poorest communities. In Leeds, there's up to 9 years difference in life expectancy between those who live in the most well-off areas and those who live in the least well-off areas. We know that the most common causes for early death are cancer, CVD and respiratory illness. We plan to tackle this issue by addressing the inequality throughout Leeds by providing extra support, such as support to access health checks and cancer screening for vulnerable groups, and putting additional resources where they're most needed, such as into the most deprived communities to support healthier lifestyles for people. This will help to prevent ill health.
So it's been a difficult time for us all, as we've been hearing, but we have managed to do some important business as usual as well. And in May, we signed off an ambitious health inequalities framework, which demonstrates our commitment to making an impact and a contribution in the city, as you've just been hearing. So I'm going to briefly outline our short and longer term plans in the following slides. Can I have the next one, please? So this is a picture of the health and wellbeing strategy, a summary of it, and this is all the partners in Leeds have signed up to this, including the CCG. And one of the things I wanted to draw to your attention is the clear vision on the left-hand side, which says that Leeds will be a healthy and caring city for all ages, where people who are the poorest improve their health the fastest. And the CCG were really keen to develop a health inequalities framework that demonstrates our contribution to achieving this clear vision. The next one, please. As you've been hearing in the video, we have a number of deprived communities in Leeds. This is determined by the indices of multiple deprivation, and we have 224,000 members of our population who live in the 10% most deprived communities nationally. We've seen this number growing over the previous years, so that's of a concern. Next one, please. And the next one. And we know that there is up to 9 years difference in life expectancy between the most affluent and the least affluent areas as well. Next one, please. But as well as the geographical differences with health outcomes, we know that we're a very diverse community and many groups are known to experience greater levels of health inequalities. Next one, please. And obviously, as we've been hearing, the COVID-19 pandemic has brought the inequalities to greater public attention. Next slide, please. Thank you. This is a graph that shows the life expectancy at birth, and the blue line shows the Leeds average in life expectancy, and the orange line shows the deprived communities average life expectancy. So this doesn't demonstrate the 9 years, because the 9 years is the difference between the most affluent and the least affluent. So this is the difference between the average and the deprived communities. And as you can see, the gap has started to get bigger. We were closing the gap back in around 2012, but it started to get bigger again. This is something that we need to address. Next slide, please. And we're committed to the principle of proportionate universalism, which is the principle that shows that you need to put resources everywhere to tackle health inequalities, but actually the people who are experiencing the most disadvantage need extra and additional resources, just as that little boy there needs 2 boxes. So this is the difference between equality and equity. Next slide, please. This is a bit busy, this slide, but basically it's showing the various levels of disadvantage that people can experience. So one of those levels would be where you live. Another of the levels would be who you are in terms of demographics. Another one would be how people treat you. So that's all about exclusion and being marginalised. And then there's health conditions as well that put people at greater risk of experiencing health inequalities. And the more of those different layers that individuals have, the more at risk they are. Next slide, please. So we know, as the video said, that the top 3 causes of premature mortality in Leeds are cancer, CVD, which is cardiovascular disease, and respiratory. But we also have that information broken down into all our different communities, and we know it can be a really different pattern depending on which community it is. So some communities might have cancer as the top cause. And some might have respiratory or CVD, and then there's other things in the mix there. So we can't, it's not a one size fits all approach that's needed. Next slide, please. The really important part of the CCG Health Inequalities Framework is the investment principles that we've signed off, and there's 4 of them. Firstly, in line with what I was just saying in the previous slide, is that we're committed to making resources available to groups of health and care leaders in the community for them to make the decisions on how to tackle health inequalities in their local areas. And we're going through a process at the moment of just working out exactly how we can do that. And then the second one is about clinicians and professionals working together from right across the system in partnership to identify ways to shift the focus away from treating chronic disease where possible and to preventing chronic disease happening in the first place. We have very close partnership working with Leeds City Council across a number of areas, but we think we can do more to agree some key shared priorities around reducing health inequalities, and we're working on that as well. And then lastly, we want to make sure that we have additional and sustainable funding for our voluntary sector organisations who have often a very specialised role working with very vulnerable and marginalised groups. And this will help us to make a difference with those groups that might not show up in the geographical data because they might be very small and scattered around. Next slide, please. So we've been going through a process of asking members of the public about the plans, and what I'd say is that broadly people from all sorts of different communities have been very, very supportive of the idea of targeting investment. People see that as fair. People were very surprised at the 9-year gap in life expectancy. That is something people were not aware of, and they were shocked. I think most people were very, very shocked by that. They enjoyed seeing a lot of detail behind the plans, and wanted to see those graphs and statistics and reasons and really get into the detail. So that was good. But we do need to provide reassurance that in taking some of these approaches that we're not going to be rationing emergency and vital treatment. So it's not that you'll only get access to A&E if you're from a certain community or vulnerable group. Those types of services, of course, will remain for everybody. And then case studies were seen as a really good way of communicating the plans, and we are planning some media focus in the coming weeks, so look out for that. Next slide, please. So as well as all the intensive planning that we're doing to decide how we're going to implement this over the coming years, we do have some really tangible things that we are doing this year, and many of these things are in relation to the COVID pandemic as well, and you'll see a list of some of the things that we're doing here. Interestingly, the Seacroft, the Beeston and Middleton one and the Leeds Student Medical Practice one are allowing us to test out some of the approach about devolving resources to local areas, but you can see that list for yourself. On the next slide. Okay, so I'm handing over to Jason now. Hopefully that was a useful whistle-stop tour of our plans for health inequalities.
Okay, thank you very much, Becky. And actually, I'd like to say thank you to everyone that has given such comprehensive presentations and information for part of this AGM, so thank you very much. Now, we've had quite a few questions submitted, and I can also see some questions in the Q&A that have been submitted during the meeting. So for those questions where we've got prepared answers, rather than people reading them out, I'm going to have them put on the website so people can read them. But there's a crossover between some of the questions in the Q&A. Now, I know Victoria needs to leave quite soon for another meeting. So, Victoria, I'm going to just hand over to you for a couple of questions that have come in, both presented and on the Q&A session here. So the first question is from Councillor Illingworth, and he says the benefits from physical activity are widely acknowledged, but can we do more to address limited opportunities for enjoying physical activity in the most deprived areas of Leeds? And I think the second question came out of your presentation earlier, and it was John Puntis who is asking, do you know where transmission is occurring for it to be rising in all age groups? So, Victoria.
Thank you, Jason. So on the first question, I have a fuller response that we can certainly put on the website, but the key points to pull out around Councillor Illingworth's question is that we have got a new scheme going live on the well, it went live on the 21st of September, which was 2 days ago, it's a new way of Leeds GPs being able to directly refer patients to Active Leeds, the Active Leeds programme that is run by the council, and also 1U Leeds, which is a public health service that we commission to support people to live healthier lifestyles. So there's a whole load of physical activity opportunities that are coordinated by Active Leeds. I'm sure you're aware of, but they include all sorts of different programmes which are aimed to cover a whole range of interests. Things like Leeds Girls Can, Couch to 5K, as well as some of the more traditional team sports. On the issue of deprived Leeds, that we've got, as you may know, we've got additional resource in our most deprived communities in the city. So in the 6 priority neighbourhoods, which are the most deprived 1% neighbourhoods in the city, we've got additional Active Leeds coordinators who work to target activity in those areas. So what the new programme very much hopes to do is join up GP practice referrals with opportunities, particularly in more deprived parts of the city. There are other things as well, such as Park Run and the work that happens through the social prescribing service, but we'll include those in the fuller report. And just on the second question around, do we know where the transmission of cases is coming from? We do get information from NHS Test and Trace and from our local contact tracing activity, which enables us to look at trends of specific places. So it might be a particular pub or bar or restaurant or gym in the city, but we also get information that helps us look at trends. So we know that the main trend for the rise, certainly in Leeds cases, but I'm aware this is also a national issue as well, is from socialising both within private households and hospitality venues, which particularly escalated in the middle of August. So we can pinpoint that to very specific establishments and households, but we also look at those patterns. So so that's why there's a huge amount of focus being put on the transmission through social contacts, particularly in young adults, much more so than the transmission through more organised settings is still much lower. So workplaces, schools, other organised settings is much lower. So I'll leave it there. Thanks, Jason.
Thank you, Victoria, and I know you need to leave now, so feel free to sign off whenever you need to. Okay, so we've got some other questions, and again, some of them there's crossover. So the next couple of questions, which are basically the same. I think John Puntis in the Q&A has asked, are funding cuts to CCG for administration fueling CCG mergers in West Yorkshire and Harrogate? And at the same time, Gilda Peterson submitted a question, which was, some time ago, the West Yorkshire and Harrogate joint CCGs reassured us that they were not in favour of amalgamating CCGs across the ICS. I hope that this is still the case, and would be grateful if you could clarify the position of Leeds CCG. So if I ask Tim to answer those.
Yeah, I'm very happy to. So the position in West Yorkshire is still that the CCGs believe that it is better to be closely aligned to our local communities at a city level. So the link between local authorities and CCGs is the key one. So we talk a lot about place, and that remains our ambition and our intent. I'm sure the financial challenges that being put on administrative costs have encouraged people in some places to look at mergers, but that hasn't been the case. It certainly wasn't the case for Leeds CCGs when they came together. It's not the case for Bradford. It's much more about alignment to, for example, for Leeds, to alignment to one CCG closely aligned with one city council, one acute hospital, and so on. So I don't see that happening here. I know in the question that Gilda put to us was also, will you assure us that you will consult the public if, for example, we were to go to up a scale and become one CCG per ICS? I'm happy to give assurance that if I have the power to do that, I will do it. Sometimes these things are decided nationally and imposed, and at the moment that doesn't seem to be the picture. We are being given the freedom, particularly at West Yorkshire, which is a good ICS, to operate in the way that we're currently operating, and that is our intention to continue to pursue that.
Okay, thanks, Tim. Another question that's in the Q&A, Tim, that you could address is, have we got an action plan to address third and fourth waves, which were in the presentation before? Okay. I think Brian's presentation might have addressed some of the third wave. It'd be worthwhile getting your thoughts on the fourth wave.
Yes, I would say the work that the group that Dr. Brian Powers led is definitely has looked at and is driving some of our thinking around the third wave and the action plans that are coming through there around our management of chronic conditions. And actually, there's already a lot of work going on about how we do that in a much better and more consistent way. And it, in truth, drives the integration agenda, I think, across the city, that we cannot address the chronic conditions that already exist, and then with the COVID implications on top, unless we work in a much more integrated, holistic way than perhaps we've done traditionally. I think the fourth wave, the real challenge, there's two challenges there. One is the economic challenge, and one is the challenge around mental health, mental wellbeing. So we're certainly looking, and some of the work that, again, and Brian's done has highlighted the importance around mental health. The challenge is going to be where the NHS puts its money, whether it puts that money in getting through the sort of elective and mental health care backlog, or into the increase that we expect over the next few years or months and years in terms of mental health and mental wellbeing. The CCG, as we've already said, is committed to not only meeting the mental health investment standard, but is going faster where that remains within our power to do so. And that will be about addressing that. So that plan is developing, I would say, on the mental health and mental wellbeing side. And there's a mental health and wellbeing strategy board, which is all the partners in the city. Really key that we work through that and with them to develop those ideas. And the mental health strategy of Leeds is a really powerful place and powerful document to drive that. I think in terms of the economic piece, that's clearly beyond the CCG, but on its own. But the CCG will be an active player in the way that we commission, the way that we try and work on the health inequalities agenda with our partners to support as much as we can mitigating that economic wave through the use of health resources as a sort of what we would call anchor institutions. Institutions employing 57,000 people in health and social care across Leeds, to try and make sure that we are key partners in minimising some of the impact, but also in driving innovation. We are a med tech city, and we would want to support that in working with the universities and the sort of business sector to really boost that part of the economy. So, for example, the Leeds development that is going on around the new Leeds Hospital or hospital buildings, new Leeds Hospital buildings, includes creating an innovation centre. And I think that is a really important part of what we want to see as a city, and the way that the health service collectively can help the economic recovery of the city from COVID. But it's bigger than us, I think, on that one particularly.
Okay, thank you. I mean, we're now after 5:30, and we were originally due to finish at 5:10, and we do have some really interesting questions, but they're quite complicated and there are many parts to them as well. So to do them justice, I think what we should do is reply to those individuals who have submitted the questions with a detailed response, but also we'll publish all questions and answers on the website as well. So I'm afraid that probably that's it for questions and answers today. Brian has sent me a message that he did want to just point out something else in addition to the answer that you just gave on the fourth wave. Brian, can you let Brian speak so he could answer that question?
Hi, thank you. This was just to allude to the 4 waves that we've been talking about, but to talk about the post-acute COVID, the first wave. So we have just launched a community rehabilitation services in Leeds, which has additional capacity in the community rehabilitation team to support patients who are left with long COVID or complications post-COVID. And this includes a referral pathway and guidance for primary care, but also the key support to patients in terms of how they can manage any ongoing symptoms post-COVID and how we can support them in healthcare. And that has been a really good example of an integrated piece of work across the city, across all providers, brought together quite quickly, but that is now quite active and it is running well. Thank you for that. Just a quick plug.
Okay, thank you, Brian. Okay. With that then, I'm going to bring the annual general meeting to a close. I'd like to thank all members of the governing body and wider members of the team for taking part today and the comprehensive presentations that have been given. I'd also like to thank members of the public who have taken the time to not just submit questions, but actually join us today and take an active interest in what we're doing. So thank you very much. And we'll close the meeting there.
Thank you.